Hey guys, this is Dr. Mahajan from Mahajan Medical Center. We got another wonderful show with our from Mahajan Medical Center studios today. Very excited that I got a dear friend of mine and a very prominent figure in our community, very uh, philanthropic gentleman, Dr. Umesh Choudhry. I know him for more than 15, 20 years, and he's a fantastic gastroenterologist. For the folks who don't know me, I'm a internal medicine physician practicing right here in Largo, Florida. And we do a webcast every Thursday. I'm sorry, every Wednesday. We changed it. So every Wednesday, second Wednesday of the month at 4:30, and we get a lot of input from our lovely audience. And it's a honor for us to bring that information to you guys on a monthly basis. And if you want to catch up on our previous shows, you can. Um, and you just need to go to our website, or you can go to Facebook Live, or you can go to YouTube and subscribe and follow us, or any of those places. You can see our previous shows, and we have a wealth of information, and a lot of patients enjoy the straight format of the thoughts coming from the thought leader. So today's guest is Dr. Choudhry. So we'll get him on our show in a minute. Here we go. Hello, Mesh. Welcome.
Greetings. Thank you. Thank you,
Let me
Dr.
ask-
Mahajan, and thank you for the audience for their time, and thank you for having me here.
So
It's
let
such a
me.
pleasure.
Yes, no, player is ours. So let me introduce you. You are the chairman for GI at Morton Plant, correct?
That's right.
Right.
Yeah, I've been in
And
this area now 22 years after I moved from the faculty at University of South Florida, and gastroenterology and taking care of my patients is my passion.
that we know, we share a lot of common patient. They all love you. Um, so let's go back to your training. So you interestingly went to same med school as mine, and we never met. You're a few years
Right.
ahead of me, and then from there you did your residency in Ohio.
Well, I started out as a postdoctoral fellow at National Institute of Health. And then I started my internal medicine residency at St. Vincent Hospital in
Indiana.
Indianapolis. And I was in the faculty there as an assistant director for medicine. And I had an advanced endoscopy fellowship after completing my regular fellowship to go anywhere in the world from American Society of Gastrointestinal Endoscopy. And I found my mentor in Tampa, Florida, and gave up Harvard for that and never regretted it.
No, we are happy that you picked Tampa Bay as your fellowship, and that led you to keep your roots in Tampa. We're very fortunate to have someone your kind of expertise. And in addition to the regular gastroenterology, which is for lower endoscopies, stomach issues, you also specialize in something unique, the endoscopic ultrasounds. Tell us a little
Right.
bit more about that.
So my to preface my claim to fame and my vision is that the esophagus or the colon or the pancreas doesn't walk into the office, the patient does. So first pay attention to the entire patient, but have a model of individualized care but specialized technology. I was one of the first four people trained in the country formally in this technique called endoscopic ultrasound, where we actually take the endoscopy and add the feature of ultrasound to an endoscope and take it inside the body to the organ that we're studying. And this has been a major breakthrough over the last 20 years in diagnosing early cancers of the esophagus, stomach, pancreas, and rectal. So many cancers can be diagnosed earlier. It can be treated earlier. We've expanded all of these now over these last 20 years into not only diagnosing of things, but also treating. So we have been able to treat patients with cancer pain. We've been able to treat people that have bile ducts that are blocked, that we can open them. And some people that cannot have more complicated procedures or surgeries, we can tackle this year actually by the technique of endoscopic ultrasound and combining cryotherapy or radio frequency to that. I have my esophageal cancer patient now spending 5 years without having had a surgery. So that is the, of course, esophageal, but similarly, we're cutting out early cancers of the stomach. We're removing, with the help of endoscopic ultrasound, we're removing early cancers of the bile duct without one ever having to go to surgery. So pancreas, of course, is another additional area.
So, the endoscopic ultrasound, if I understand you correctly, get you close access to, those abnormal tissues, which, was difficult before pre-EUS time where we were doing from outside. Now you're right next to the pathology and you get a much beautiful image of the pathology. And then you have it there so you can biopsy it in a outpatient setting, correct?
Correct. And the other thing is sometimes patients had to go through surgery and then surgeries were not successful because patient was found to be not resectable. So we can identify, early diagnose, stage them, and then have those same people not have to go through surgery and say, okay, here are the people that will go through curative surgery, and here's a group of people that we should not make them weaker by putting through surgery that they do not need to. So there's a tremendous amount of quality of life, there's tremendous amount of cost saving and overall health promotion.
That's good to know. So let's go to, we have a large area to cover today. So let's go to that. Let me bring up our topics we're going to cover. So here we go. We're going to be covering a big area. So the liver, gallbladder, pancreas, and we introduce our guest today, Dr. Choudhry. He's chief of GI at Morton Plant and very well qualified to talk about these topics. And he brings the exciting endoscopic ultrasound techniques to our forefront in Tampa Bay area. All right, so let's see. All right, so let's see what we have on our agenda today. We'll start with so that's Dr. Choudhry's
That's
lovely.
yes, exactly. As the best saying goes, I'm just a small cog in the wheel. This is my whole team that helps out. I have some. I've been fortunate to have some really helpful people in my team. My physician assistants, my nurse practitioners, and of course the staff that interacts with you. My partner, Dr. DeGala, over there.
Right. So yeah, he got a beautiful office as well, and his lovely wife, the boss, is behind the scene.
Of course.
All right, so we're going to talk about liver first, Umesh, and as you pointed out in this slide, um, that liver is the largest organ, and and you can't live without it, otherwise you'll die. People with cirrhosis knows how difficult it is to have a non-functioning
Right.
liver, and then a lot of people don't realize the liver is the major organ where you get rid of all the chemicals and the toxins. So it's a very key organ, and it
Right.
makes bile and store glycogen. So we'll talk about some of those topics with you in a minute. So let's see. So that's the liver, how it looks. Has two lobes, has a beautiful smooth surface, and it's right below your right lower rib cage. And typically, you should not be able to feel it unless you have experienced hands and you have the patient lay down. But if you can feel it, that means it's bigger. So that's
Yeah.
something you should not be able to feel unless it's enlarged. Right. So you want to talk about what we see here, Umesh?
Right. So as you rightly pointed out, it's kind of amazing how silently our body works, and until it cannot, I would say, liver probably is the most forgiving organ in our body. It can get bad and it can disease up to 70-80%, and it can still regenerate and repair itself. I wish our brain was that good. So the picture that you just showed, here's a gentleman with jaundice or yellow color of skin. This is, of course, very deep yellow coloration of skin. So the idea is that liver has a three-pronged function. One, it'll clear all sorts of toxins from your body, the medication toxins, the ingested toxins, or when we eat all the food that we've consumed, the food that goes in, the breakdown is ammonia. It clears out the ammonia, turns it to the urea that can be then worked out through the urine. So liver works in a great conjunction with the kidney. So when that balance is lost, liver also produces what we call proteins for clotting. Your blood clotting can become weaker if you don't have it. So the patient often may have pain because the liver is sitting right next to the diaphragm. So you can get sometimes chest pain, or you can get sometimes a pain in the upper abdomen. But some people could silently just become yellow. And that is the extreme case of yellow, so-called the yellow jaundice that you saw. So patient's family will notice, oh gosh, my dad or my family member is yellow. And that could be sometimes the most common presentation. The things that diseases that occur that cause this sometimes are infections, which we call hepatitis. Sometimes is a problem with the bile that the liver produced. If it does not get out into the intestine and it gets blocked, that can cause yellow coloration of skin, and that can cause pain. So hepatitis infection, like you've heard about hepatitis B, hepatitis C, and you've heard about medication-induced hepatitis, or you can get hepatitis A, which is from food sources. So the hepatitis A, of course, is you acquire by eating tainted food, but it's not a chronic thing. But B and C are the major things that we need to be knowing as chronic. You have about 3 million cases of hepatitis C in this country every year. So it is almost going to be that we will start testing patients, what we call the baby boomers, people that came around in that baby boom. From them, we'll likely start testing them regularly as a routine as you get tested for say thyroid disease and all when you get over 50, or as you get tested for colon cancer. It's a blood test that we're going to get there because the
Let
treatment
me
of
stop you
hepatitis
for a minute, and I just wanted to bring a very interesting point which you were alluding to earlier. A lot of people who had some fun parties and some in their 20s and 30s, and then they forget about it, and and they are asymptomatic, and they come for a routine physical in their 50s, and then we see a little bit elevation of their liver enzymes. And I think you bring a good point that they should be screened for hepatitis B and C, especially with the fantastic treatment options we have, especially for Hep C. Hep B is okay, but Hep C, 90, depending on the genotype, 95% cure rate. So there is a wonderful opportunity to prevent cirrhosis and serious liver damage if we can catch it early. Correct?
Right. So this is actually, Dr. Mahajan. I'm glad you brought this up. The point of all of what we do is that by the age of 50 and all, we've worked hard. We've worked really hard. We've done our thing. At this point, if we can do small interventions that can make a big difference in quality of life and eventually reduce the burden of cost that comes from a devastating illness. Hepatitis C is a perfect example of that. There was a time when you and I were, coming out of med school, this was like a death sentence. Then we went into our residency and fellowships about 20 years ago, and people were getting treated for a whole year. Now, in 8 weeks to 12 weeks, we can take care of 95 to 99% of the hepatitis C patients. And basically, it's almost like treating an infection of the throat or something. So that's a major achievement, because once you treat that, not only you've made a really great improvement. One, that you have prevented the liver from going into a severe cirrhosis, which is hardening of the liver. And then the risk of developing cancer of the liver has been interrupted. And I hope I've answered that.
Right. So, I think a lot of people think that if Hep C is gone, they have zero chance of hepatocellular cancer. That's not true as well. But yes, you're absolutely right. The chronic inflammation will be less, and hepatocellular cancer will be less. But they should be still screened, even if
Right.
they are RNA free, with the tumor markers, with the blood tests once a year, and the ultrasound.
Very good point.
Correct.
Right.
Okay, let's talk about a very common thing we see nowadays with the epidemic of obesity in United States, which is fatty liver.
Right.
Everyone,
Can I interrupt for one
Sure.
second? We forgot to say that make sure that people that have not received hepatitis B vaccination must get hepatitis B vaccination. Everybody that's born in the United States after 1989 has been regularly getting hepatitis B vaccination. But we have a country of immigrants, and so people that are coming from abroad, people that have been born here but extended stay outside and didn't get the vaccination.
and to that point, in Pinellas County, we get periodic episodes of hepatitis
Hepatitis
A as well. So, there is a vaccine for that, especially someone who has compromised liver, alcoholic liver disease, or chronic hepatitis from autoimmune disorder or any other disorder. They should get the hepatitis A vaccine as well.
Vaccine. Yep.
So let's
Thank
say
you.
A and B, and C. Unfortunately, we don't have a vaccine yet, but
Hopefully.
with the COVID mRNA technology will open doors for these viruses as well. But yes, so your point is very important. Coming back to the fatty liver, the silent epidemic, we're seeing so much fatty liver. You do ultrasound, and anyone in their 40s, late 40s, 50s, and invariably you're seeing fatty liver. Tell us the story. Is it benign? Is it just the fat hanging out, or it's the number 2 cause for cirrhosis now?
So if you notice on that slide, I made fatty liver really fat. Primarily because emphasis is due where emphasis is due. It comes at the bottom because that's how the progression and evolution of our understanding of liver disease has been. But by 2050, fatty liver will be the single biggest cause of liver transplant in this country. So if we keep scaling it back, we're already in 2020. Fatty liver is the fastest rising liver disease in this country. We're eating ourselves to death, and our activity. My biggest pet peeve is that person that comes to the house on the driveway and sticks their hand out of the car's window, takes the mail while in the car, and then drives the car into the garage. We really need to have a extended attention to activity as a lifestyle, not only as a prescription. Secondly, we really need to pay attention to what we're eating, how much we're eating, and how much of that we're burning. So, what goes into the body. And there is also, so obesity is rising starting in our teenagers. Obesity is rising in middle-aged people. Obesity rising in the elderly, and then along with that, diseases that impact this, something like diabetes. So we're in an epidemic of what we call NASH, non-alcoholic steatohepatitis, or non-alcoholic fatty liver disease, and alcoholic fatty liver disease. So all of this is rising. What we need to do is, as a community, be aware that here's a silent killer. If you thought about hypertension as a silent killer, you thought about diabetes as a silent killer. Here's another silent killer that will keep your liver will keep helping you till you get to a point where it's progressed to steatohepatitis, or begin to then go into cirrhosis.
And there is some interesting data recently about coffee drinking and maybe some beneficial effect on the fatty liver. But before we come to, as you rightly pointed out, before we start thinking about coffee as the panacea, we need to do the lifestyle changes. We need to,
Right, right.
not have processed food,
Moderation.
portion control, and as you said, mobility. Moving is critical. And as we get into change in life, both for men and women, that's when we're seeing fatty liver mostly. That's when your metab is slower, and you got to work even harder in terms of portion control and exercise. Let's bring alcohol back in
Can
the.
I point something else? We actually have two new techniques. FibroSure and FibroScans we're doing for. So once we identify the fatty liver on the ultrasound or by lab tests, we're doing what's called fibroscanning. So it tells the degree of fibrosis that we pick up early, and steatosis or fatty liver that we pick up early. Then we are now participating, at least at my office and in my group, we're participating in a study, that a registry of the national registry of the fatty liver patients. So we're tabulating people that we have. We're going to study them, and I actually have a couple of clinical trials of the upcoming medications for fatty liver. So there's a lot going on that I, as a gastroenterologist, have also progressed further because the diseases are progressing. Sorry.
Right, right. But again, part of what we do is education. So if we
Yeah,
can prevent it, that's going to
definitely.
be the key point. And the prevention is knowing that if you're diabetic, if you have truncal obesity, if your BMI is, in Asians, Southeast Asian is another interesting subgroup, Umesh. What I see, we are more skinnier by genetics, but
But we
the
still have fatty
standard
liver.
BMIs, what's used for Caucasians, does not apply to us. We need to be extra careful in 25 BMI in Southeast Asian with truncal fat is a risk for fatty liver and coronary artery disease and diabetes. So you got to look at ethnic groups differently in terms of
Differently.
how you look at them. Let's talk about alcohol for a minute. I know no one wants to hear about it, and everyone thinks someone else will get alcoholic liver disease, but that's one of the key piece of take home, if we can send it to our audience today, is as we age, the liver is unable to metabolize the alcohol as efficiently as when you're in your 20s and 30s, and you can have tequila shots and whatever your beers, and you can go next day and do your residency or whatever your jobs you're doing. As we get in our 50s, especially in women, the metab for how the liver process alcohol become extremely slow.
Hmm.
And if we keep doing what we're doing in our 20s, 30s, and 40s, in our 50s, we are asking for trouble.
Right. Yeah. So it's interesting. Alcohol is a perfect example of you take a small dose, it's a medicine. Almost all of our medicines are like that. You overdose on a medicine, it's a poison. Alcohol in a alcohol is a part of community. We just have to take it for granted. You cannot have fun without alcohol. Most people. You have functions, you have celebrations. Alcohol is an integral part of it. Again, just like so many other things we do, in this also speed kills. You really need to drink slower than what your liver can metabolize. You need to drink less than what your liver can accommodate. So substantial alcohol drinking is defined as more than 3 drinks a day for more than 5 years. So just imagine how many people will come into this category of heavy drinkers. And one drink is defined as 1 ounce of hard liquor, 4 ounces of wine, and 1 small bottle of beer. They all are equal. So people that say, oh, I just drink beer. Well, it depends how much. So, and how long over a number of years that is done. We have, just imagine, of all the alcohol drinkers in the country, and you got to see almost everybody drinks. So if you have heavy alcohol drinker people, as I defined here, so somebody that drinks more than 3 alcoholic drinks for more than 5 years at a time are now defined as substantial drinker. 1/5, so 1 in every 5 of them is likely to get into alcoholic liver disease. So that's where primary prevention is. We all have to look at ourselves. We got to look at our family and start that process that here is a wonderful invention of mankind. And, liver does not care for how expensive your liquor was. That totally does not. It really gets hurt by any amount. It just only cares about the dose of the toxin or dose of the drug that you're putting in. That's what it has to work with.
And
I
a
hope I
lot of
made that
people
clear.
do. A lot of people do. I'm sorry. A lot of people do binge drinking. They work hard on weekdays and then they party on the weekend, and the binge drinking is equally bad. So you got to, as you said, look at how much alcohol you take, and maybe small is good, but don't get carried away. Let's say hi to a lot of folks who lined up to say hi to you, Dr. Chowdhury. There's a
Greetings.
lot of fan base here. Jamie saying hi. Hi, Jamie. Thank you for tuning
Oh,
in.
hi, Danny.
We got Radhika Sharma saying hi, Dr. Chowdhury. Hi, Radhika, for tuning in. We got
Greetings.
Deborah saying awesome stuff. Thank you for
Hi,
tuning,
Deb. Oh, wow.
enjoying our what we're producing here. Ray Davis is saying, Ray and Caroline saying they are regular listeners. Hello, Dr. Mahajan. Hello, Dr. Chowdhury. We got Miss Fink saying, hello, doctor. That's interesting. Thank you, Miss Fink. We got our favorite Humana rep, Jenny, saying, hello, Dr. Chowdhury. uh,
Hi.
let's see. Oh, she's at best guester doc ever. you must be, you must be having some, you know,
Well, sometimes old age has
rep
benefits.
to one of our patients. She's a very successful Humana rep. Wonderful, wonderful rep. All right, here we go. Fatima is saying thank you. Thank you, Fatima, for watching. And Fatima is saying hello, Dr. Chowdhury.
I think
Hello.
Fatima she gave me my COVID shot.
Yeah, Fatima is a wonderful nurse practitioner. She works for Baycare, and she does a phenomenal job with giving shots very slowly and smoothly, and not in the butt, but in the arm, right?
Right.
All right, let's talk about the meds too, Umesh. I think as I see geriatrics, and you see a fair bit of geriatrics too, we in Pinellas County, we all see geriatrics. I think the medications, people don't think about medications or what they put in their mouth as medication. Anything could be medication, whether it's you write a script, I write a script, or it's over the counter, or it could be herbs they're getting from the health food stores or online. Could
Right.
be anything you put in your mouth has to go through liver. And we see so much damage done by medications.
Medications.
So what are the common ones which comes? I'll say a few and you can fill in the blanks. So the Tylenol is obviously something we got to be careful again, not to say you should not use it. It's a very safe drug, but as you said, little is good and too much is not good. But Tylenol along with alcohol is not very good. So that's number one in my thinking. Number two, NSAIDs, a lot of Aleve, ibuprofens of the world's, naproxen, they can damage your liver. Um, and there are a lot of other prescription. Any drug, any chemical, if you ingest, has to go through liver. Anything else you want to add to the list?
So, the most important thing I want to emphasize here in Pinellas County or in Florida as such, or in the aging population per se in the United States, age and number of drugs put together. We really need to assess. We used to say over 60 and more than 6 drugs, you better start watching because you might hurt either the kidney or the liver, and that's the thing. And now imagine how many of people that we have here that are over 80 and 8 drugs. So combination of drugs and the drug salad, as I call it, is really important. So what we need to think about is things such as, say, your the statin drugs, and you combine statins with antibiotics that, say, erythromycin or clarithromycin, Biaxin, azithromycin, that group of antibiotics that need to get clear with the liver. And then if you have any medications that are if you're treating for a chronic illness like, say, tuberculosis and all, medicines that may be given for several weeks at a time. So those are the ones that come to mind. But now, if you notice, we're also getting long-acting medications. So there are lots of medicines we like to take them once a day, but those medicines are longer acting, and hence they persist in the system, and we need to watch out for that. There's a whole long list of these medications, and especially if you're getting medicines, say, for people that have cancer chemotherapy, there's a whole array of medicines in that regard also. But antibiotics are one. And then please, on a Friday afternoon or a Friday evening, when you're headed to, you came back from a game of golf, and then you might be headed to the afternoon or evening dinner, please don't take Tylenol before you go to the bar. That's just a no-no.
Right. And, also we need to point out that no medication is safe. Any medication taken for longer period of time, as you said, will either hurt kidneys or liver. So it's good to get your, if you are on chronic medication, especially older folks, anyone above 60 is old as far as liver and kidneys goes. Unfortunately, they get, slower in their robustness in clearing these medications. They should get, at least once, twice a year, if there are more than 2, 3 drugs, twice a year, liver test or kidney test or both. And a complete metabolic panel is, not expensive, and most of the insurances cover it. So, absolutely. The other point to consider is, if you getting medication from multiple providers, let's say you see
I
me
was
and
going to bring that
then
up.
Choudhry, and a lot of folks don't know the brand name, generic name, and unless you. So what I tell patient is two things. One, make sure you take, the med list from your primary care to your specialist. So that way they know what you're getting, and you're not saying the blue pill, the red oval pill. They don't know. It's just hard. And number two, once a year when you're doing annual wellness with your primary care, bring your brown bag in a U-Haul and bring all your supplements, all your over-the-counter drugs, and whatever you're getting from specialists to your primary care, and have them look at it. See if there is time to wean out or weed out drugs. A lot of time, we physicians are very good in giving medications, and we are very poor, me included, in our rushed lifestyle and rushed seeing patients volume, that we don't take medications out. So it's a very important thing to make it part of your annual wellness to see if any of these medications can be eliminated. And that's to me is huge. I tell all my patients, bring all your meds and let's look at indications. I saw a patient the other day, and poor guy has been on blood thinner for 2 years, and he just had one pulmonary embolism. And the older folks, the risk of falls and bleed is such high, and we giving blood thinners left and right, and not thinking when to stop it. So it's very important that as a collaboration between patient
Right.
family, primary care or nurse practitioner, whosoever you see once a year, part of your annual wellness, bring your medication, bring your supplements, and be open-minded that okay, it's maybe time to reduce your trazodone. Maybe it's time to get rid of your flexeril. You may be liking it, you may go through withdrawal a little bit, but these are the medications which will cause you confused because the liver can't process them anymore. These are the medications which will make you fall, and then it's too late. You get a hip fracture or something.
Right.
All right.
So you bring up a really important point, and I think specialists like me are have to be extra careful. That's why I like working with strong primary care physicians like you, because that the role of the quarterback, as I call, of the team, is to make sure that other people that are likely to be seen once or twice a year haven't started something that might then not get discontinued. So you bring out a really important point. And medicines that are given for seizures and epilepsy and the anti-anxiety pills, long acting. Those are the other two group that you bring up. Thank you so much.
So we got your friend Sanjeev Jain saying, "Hi, Dr. Choudhary. Hi, Dr. Mahajan." He's looking handsome in his
What's
picture.
he doing watching us at this time? We should be working.
His wife is not going to be happy. All right, we got a good question from our friend Jenny. She's saying she's seeing more and more people taking Eliquis and Xarelto. These are the newer medications. She's wondering is their effect on the kidneys and liver. All right, let me address it, see if I missed something, Umesh, and then you can take it from there. Jenny, very good question. I think the blood thinners are serious drugs, and they have improved quality of life in a lot of patients who are taking Coumadin because they don't need to, get their blood tested, and they don't have to be restrictive in their diets as much as they were with Coumadin. But on the flip side, these drugs are very serious drugs, and in older folks, if you don't watch, how the kid. So the answer to the question is there is no direct effect. So let me make it clear what I mean by direct effect. So let's say if your kidney functions are weak, that means your EGFR, which is a good indicator of kidney function, if it's less, then we use less of these medications. So your point is well taken. If you don't factor in the age, their body weight, and the EGFR, and liver has a role to play too, but
Mhm.
primarily they are excreted to the kidneys. And if we don't factor that in, and we give them the full dose of the Xarelto, Eliquis, and Protexta, and there's another one in that class now, then they will have more bleeding. So they can have spontaneous bleeding anywhere in the body, from brain to anywhere else. So yes, you got to be extra careful with these drugs. And I'll have Umesh talk about if their liver is not working well, how to be careful with these drugs. Go ahead, Umesh.
Yeah. So the idea, the problem with some of these newer drugs also is they're they were designed so we wouldn't have to do too many tests to figure out how the function is. So you don't realize until the patient starts bleeding. So the impact of liver disease is definitely there, and the test to test for, say, how much Coumadin you have, you can check their PT-INR. But with some of these newer medications, you have a hard time check this. So we're not specifically adjusting the liver the doses to begin with, but we're kind of going by trying to see, say, if we start out with a lower dose and see if our function is working.
Right. No, that's a good point. So, any time you have liver disease or chronic kidney disease, you give small dose and build up. Let's bring another slide you brought to Mesh, and that's a good slide, gives a good overview on the different tests. If you have any jaundice or liver enzymes were up, and we want to see what's the cause for it, and you touched on a lot of those causes, these tests will give us a better understanding of the pathology and the treatment modalities. So, these are testing which, we order all the time. So let's go to the next slide because we got a lot of topics to cover today. Unless you want to add something in this list, Umesh.
No, these are, people are very familiar with the ultrasound. They're familiar with the lab tests. If you have hepatitis, if you have hepatitis C, if you have hepatitis B, instead of doing the chemistry profile once a year, you're probably better off. You would require to do it twice a year instead. Ultrasound is a very non-expensive and a good test to do, and that does not have radiation. So it has a starting role. So don't tell your doctor to get an MRI because you heard about it on YouTube or on this show. Ultrasound is a really good test to start out with as a screening tool for these things. And then you'll see things like MRI, MRCP. Everything gets more and more specialized and hence more and more expensive. ERCP here you would see, and then a test spyglass, and I can tell you, ERCP we have been using now for the longest period of time to really tackle the gallstone that I would say that went rogue. So, kind of take a step back. Gallstone disease is almost, at any given time, we have about 60 million people in this country that have gallstones. But that doesn't mean that they all have stones that require treatment. Yep, this is a good one. So our activity, the way our diet is a high fatty diet and lack of activity, diabetes, all of those things result in stone formation. It's one of the most common diseases or common conditions we can have. These stones in half of the people, so if you have 30 million people that have stones, 60 million people that have stones, only about 3 million are the ones that get symptomatic every year. And half of them, so 30 million people, would go through their life without ever knowing they have stones. Some of those stones go rogue, as I say. They are small enough that they actually go from in that picture, they go from the gallbladder and move into the bile duct. When a stone moves into bile duct, that becomes a urgency, if not an emergency, because the bile flow would be stopped and you could get yellow, you could have pain of your life. You are so close to the pancreas here. If you see on that picture, that stone, as it traverses the bile duct, it can also cause pancreatitis. So here's a stone that now cannot be managed without intervention. Years ago, we used to send this person to a surgery. You had an open gallbladder surgery where you had a big, nice incision. The surgeon actually manipulated the bile duct, and then you had a tube hanging for weeks. Now we do this test called ERCP, and that ERCP goes, the opening of the bile duct, I tell people often, is as tiny as the little ballpoint pen's opening. So you try to get in with this scope, as you see. And if Dr. Mahajan, if you have a pointer, you can point out, but that arrow that shows in this picture, in both these pictures side by side, is pointing to a stone that's stuck in the bile duct. This stone will lead to jaundice, yellow color of skin. It'll lead to a horrendous pain and sometimes lead to what's called cholangitis, which is like you get a septic infection. So this becomes sort of an emergency, and most of the time urgency, but sometimes emergency that we can tackle. And I have specialized training to handle that. Here's a basket bringing that stone down after we've cut into the bile duct. And all of this is being done, as I say sometimes, we're working about 4 feet away from where the stone is. So you try to work with a tiny little equipment that's the size of a ballpoint pen, and you're working from 4 feet away. So this requires a great deal of precision and specialized training that not every physician or every gastroenterologist is trained to
I
do.
know the gallstones are so common, Umesh, and let's hit on some controversial aspects of gallstone. Um, so you do an ultrasound. Patient is symptomatic. They had something else, and you did an ultrasound. Let's say for kidney, they had a hydronephrosis. You want to follow up on the hydronephrosis. That means the fluid is backing up on the kidney, and then you see a gallstone. So what you do with that? Just wait and watch. Tell the patient to lose weight, drink a lot of fluid, small diet, less fatty food. Anything else?
Well, the idea is, since I have that literary bent to what I explained, my answer is do not go romancing every stone. Leave it. If it is not causing pain, if it is not causing symptoms, do not touch that stone. That because you have a stone, you don't have to go romance it. Leave it there unless there are gallbladder type symptoms. So this is where first thing the patient will come to you and say, or you will tell the patient, hey, your kidney stone is okay. Your kidney stone is causing you the problem. I also found some gallstones. I'm going to leave it alone. Do not think that I didn't know about it. I know about it, but I am going to not act upon it because that is the appropriate approach. So stones in the gallbladder, approach them, treat them only if they start to cause gallbladder type symptoms, which would
Yep.
be pain on the right side, and some people would describe as indigestion, ajda. I eat and then I get a little bit discomfort. I get very burpy, and I do not, in 2021, I do not want to bring the fat fertile female of 50, but that was the acronym we learned in med school. I would just say fair and well built, still a fertile female in 50s and 60s or 40s could be the person that actually is likely to get the stones. That's the most common.
So the point to take home is if you have a gallstone, you don't need surgery unless they are symptomatic. And even then, maybe they can do ERCP and loosen up the sphincter, and you may not still need the surgery if the gallbladder is in good health. Correct?
Correct. Yeah, especially in the very elderly, what we are noticing is that if you did what we call an endoscopic sphincterotomy, remove the stones, and you have a good enough sphincterotomy, that in itself could be considered a adequate treatment, and you may not need the gallbladder surgery. But in a younger group, where you're likely to be able to form more stones, a laparoscopic gallbladder surgery at that time would be the standard of care
All right.
and less invasive.
I'm sorry. You had something else to add?
No, that's good. Thank you.
All right. So the next organ next to the the common bile duct and the liver is our friend pancreas. And
Yes.
you normally don't hear about it till it's get angry.
Right, right.
The minute it get angry, it will let you know. It's one of the worst pain you can have. Some people say it's worse than childbirth or kidney stone. So it's a very serious pain in your. And the thing about pancreas is that some people think it's their back because it's the organ which is in the back of your belly. So you got
Right.
to be very careful if you have history of gallstones and or you drink alcohol. There's a good possibility that if you're having pain going to your back and you're throwing up, that it's not that you lifted something heavy which did it. It could be that too, but you have to think about pancreatitis, and the consequences of pancreatitis are serious if you don't get attention, and you need to go to the hospital because you need to not eat and get IV fluids, get pain medication, get testing to make sure there's no stones. If there are stones, then we need to get that taken care of, get the gallbladder removed if the gallbladder disease. So this is something you cannot ignore. Anything else you
Right.
want to add to that point?
Um, Pancreas is to be dealt and handled with a great deal of caution. Unlike the liver, like I told you, that, or I told the audience that liver is very forgiving. It'll come back, it'll repair itself and do. Pancreas, when it gets angry or when it gets, say, inflamed, it sometimes may have lifetime's consequences on it. So so the most common cause of pancreas getting angry, so to say, or getting pancreatitis is gallstone disease. That often is an acute pancreatitis that then gets better without consequences, as long as we know that we've taken care of the problem, which is we've handled the gallstones by removing the gallbladder and improving our diet and improving our activity and avoiding alcohol. The problem comes with recurrent attacks of pancreatitis, and some people have immune, their immune system is such high functioning that they actually get a very severe pancreatitis right up front. So once you've had a pancreatitis, you really need to have a lot of attention paid to your lifestyle. If I tell you that, okay, you've had a pancreatitis that was from alcohol intake, I would tell you alcohol is bye-bye for you. You may take a sip here and there because it's not good to tell people that you're being deprived of something. But substantial alcohol intake, you're going to cause yourself life-changing problems. So that's number one. Then, of course, we need to be paying attention to what, anytime your medications are written, and if you've been on pancreatitis, you want to make sure you check with your primary care physician, your pharmacist, that, okay, are there any medications that could hurt my pancreas here? And you got to be really careful about that. Again, there are, every year, a new drug or 10 drugs get added to this. The drugs list, if you see, that can cause pancreatitis, about 1,000 medications, and they are different things. But blood pressure medications and diuretics, thiazide diuretics, and even something like acid suppression medications. So there are lots of these common medicines that can cause pancreatitis, and you have to be careful.
All right, so let's talk about the biggie now. You mentioned the gallstones, the most common cause, and alcohol and medications, which is critical. A lot of people don't think of medication, but the ACE inhibitor, HCTZ, as you mentioned, and a lot of other medications can do that. But the thing people worry about the most is pancreatic cancer. The reason for that is by the time you diagnose, it's already metastatic. And one of the figure you showed up there is very scary. So you get
Correct.
60,000 cases and 40,000 deaths. 400,000 deaths. I'm sorry. 60,000 cases. No, 60,000 cases and 40,000 deaths. So that means hardly anyone survive the pancreatic cancer, Umesh. So that's a
So
serious
here,
cancer like ovarian cancer, which is hard to diagnose, not symptomatic till it's too late. So any advancements on tumor markers or any other techniques that we have coming in future to pick it up early?
right. So the issue really is that it's certainly not, it's about seventh or eighth in the hierarchy of common cancers. So it's way, way down there as far as number of cases occurring every year. So, lung, breast, and colon, take, and of course prostate. Those are, the most common cancers, but they don't kill as much as high of a percentage as you'll hear about. A lot of people having other cancers and then making it, 5 years. The 5-year survival rate a couple of years ago was about 7 or 10%. So the idea lies. So here's a cancer that you see in this picture. It's already growth in the head of the pancreas, and it's already involving the duodenum. It's projecting into the intestine. And if you see the next picture, where here is what we would like to catch all pancreatic cancers, where it is limited to within the pancreas and is less than 2 centimeters or less than an inch in size, where we can actually completely remove that part of the pancreas and give a sort of curative response. The key in these is that we, at least in the United States, have not, none of our societies, including American Cancer Society, has yet taken this approach of taking tumor markers like CA19 or CEA, the carcinoembryonic antigens, as screening tests. Some of the European countries are testing these out as screening, and we believe here, at least in the United States, that approach leads to many more unnecessary scans. In endoscopic ultrasound in the last 15 years, and that's how my interest grew in endoscopic ultrasound. Endoscopic ultrasound has had a substantial, in the early diagnosis and staging of the pancreatic cancer, and our ability to do a fine needle aspiration. And so we can put an endoscopic ultrasound scope and get to that area where the cancer or the growth may be, and put a needle in there and get a biopsy rather than going from the skin, because then the biopsy is coming from that area where, if we find cancer, it will get removed. And so there's no chance of needle spreading anything else. So that's one of the things. Now we're also trying to say triage people. We're very close to saying that if you have a family history of pancreatic cancer, you could go to a screening endoscopic ultrasound before you even have other tests, or have a screening MRI, because some of the CT scans may not detect things early. We're likely to get into some of the tumor markers that we may have identified. There is an association of BRCA, the BRCA gene that people know really well from breast cancer and colon cancer. So if we identify those genes, then we can identify some people with pancreatic cancer early. We also have hereditary pancreatitis. It's a definite group of people that have a higher risk of developing pancreatic cancer. So we sub-fragment all comers into various of these groups that then say, okay, these are the people that we are going to study much closer than a random person. So this is an evolving field. Endoscopic ultrasound is definitely added to our ability to identify resectable from completely resectable to non-resectable patients, so you don't take people to unnecessary surgeries, and so on and so forth.
Is there a role for lifestyle changes like quitting smoking, losing weight, alcohol reduction in pancreatic cancer being less?
Right. So there are about 9 or 10 different interventions, and smoking gets like first 4 or 5 of those. So yes, there's no doubt tobacco has a clear-cut role even in pancreatic cancer. BMI over 29 and 30 itself, again, is a higher risk for pancreatic cancer, colon cancer. So GI cancers and obesity have a higher role. Patients with diabetes have a slight preponderance of pancreatic cancer. The other thing that, and I don't want to, in my excitement, not to miss out on something, but the prevention. The coffee has been on both sides of some people initially thought coffee causes cancer. Then some people started saying that, oh no, coffee was actually protective. So right now we'll leave coffee away and then just say we do not know whether a moderate or mild coffee intake has any downside. Alcohol, yes, by causing chronic inflammation. If you run into chronic pancreatitis, you put yourself at risk for developing pancreatic cancer also.
So you brought this slide, Umesh. You want to tell the audience what you want to show
So
here?
this is a slide actually unrelated to pancreas, but this is a slide that I wanted to highlight on early detection techniques. So this is a this is what we call laser microscopy. This is the newest technique that every couple of years I bring in a newer technique. So this is a newer technique for diagnosing very, very early cancer focus. And this is a slide in the esophagus, actually, where it's a volumetric laser electron microscopy. So this is the next step after endoscopic ultrasound, where endoscopic ultrasound goes it's the sound wave. Here we are taking actually a laser wave, and so this whole thing that you are seeing as about a centimeter thick is only as thin as the top layer of your skin. So you can imagine the degree of magnification that we are able to achieve in your endoscopy centers. And this is not a research tool at this time. So this is where we're headed.
So is it useful for Barrett's and all those conditions?
This is definitely, this is where my major approach has been. So this patient that I described to you, the guy that was a hospital executive 5 years ago, that I identified as a early esophageal cancer, not dysplasia, not just plain Barrett, cancer in there. I put the endoscopic ultrasound for him, and identified an endoscopic ultrasound did not show it as deeper. I did this laser electron microscopy there, and then identified the area that had the cancer. I cut that out with the advanced endoscopy technique, and after that, treated him with what we call cryotherapy, froze the rest of the area of the Barrett's esophagus, and this year he's going to complete 5 years. We've been following him with the CT scans. He's been, very, very thankful. And now we have at least 7 or 8 cases now in different, years of follow-up that have complete resolution of cancer in the
Now,
esophagus.
this new technique as well, the endoscopic cystogastrostomy, you want to talk
Right.
about?
So this is again to avoid surgery. So if you see this round glob, the black, the little one, this is the big one. So that's the cyst. So a lot of people with pancreatitis, they develop pancreatic cyst. So if they are not drinking alcohol, they are following the right lifestyle, and they have developed this what we call a pseudocyst. What used to be done was they would go to a surgery, they got a big gash. Now we can drain through the stomach, put a wide bore stent, drain that cyst, and have the cyst collapse. My most impressive example, where you'd see in one of these next slide, where you see this whole big pancreas that I took out. This is a young, unfortunate young girl that, with her first pregnancy, she had pancreatitis, really bad pancreatitis, that she had a 20 centimeter pseudocyst that I drained with a stent, and what we call pancreatic necrosectomy. So we then go with the scope into that pseudocyst in the pancreas and pull out all of the dead pancreas. And that, you see, there are 2 scales here. You notice one scale is 6 inches. The pancreas that I took out was so big that you have 2 of those scales measuring scales by side, and that's the whole pancreas out. She had such a remarkable recovery after that without surgery. 20-year-old.
Right. So, people think alcohol and gallbladder, but there are other rare causes like, pregnancy-related pancreatitis as well.
Right.
So, coming back to our motto of prevention,
Right.
in terms of liver cancer, in terms of pancreatic cancer, gallbladder cancer, not that common either.
Right.
What common theme coming through again? Is it not smoking? Is it getting you screened for Hep B, Hep C, and getting it treated if you find it? Is it lifestyle changes, making sure your sugars are under control? If you have cirrhosis, you increase hepatocellular cancers too. So if you cut back on the alcohol, or autoimmune disorders, then if you get it treated earlier. And then we talked about role of the medications. So less is good with medications and exercise. Anything else which will prevent cancers?
Well, I think the whole concept, I tell, again, a semantic approach to making my point to my patients. If you're going to go out and get in your car and you're going to wear a seatbelt, but then you're going to go and just sit around, no exercise, you're going to drink, I think you should stop buying insurances and life insurance, all that. If you really want to take care of yourself, then lifestyle, health as a part of lifestyle is to be intertwined. You have a healthy concept that you really need to take care of this body, and you can't just pop pills and make yourself better. Your body needs to be in harmony with what you are able to achieve. So what you put in your body, what you eat, how much you exercise, how much you give stress has an immune response that we know that all of these conditions that we did not highlight this, but stress and causes, we know now, that stress can have an exaggerated response of how the body reacts, and stress can reduce the speed at which your body can heal itself. We also know lack of sleep as a carcinogen being identified. So those are the things that we really need to pay attention to, that things like tumor necrosis factor in our body. Tumor necrosis factor is a very interesting concept. These are factors that keep the tumors from growing, they keep them down. So when you have a stress level go up, the production of tumor necrosis factor goes down, so tumors can grow more. So when people realize that, oh my God, he was okay, but then, stressful lifestyle, and then suddenly something happened. So your body tries to deal with things as long as it can, until you, try to make it do more than what it should. So eat healthier, exercise, pay attention to obesity, make sure, for men especially, visit to the doctors need to become a lifestyle. And I'm telling this to myself also, and my primary care physicians obviously remind me often, doctor, heal thyself. So same situation, we're very busy, professionals, we need to have goals, but this is a goal. You look at yourself and say, these are the goals. Women are better at going to the physician, but the men, especially middle-aged, active, go-getter, executive, that's the guy that really needs to be very careful about prevention. Did I say
Good
that?
point, Umesh. In terms of, so we covered from liver, then our journey took us to gallbladder, then we went to pancreas. Anything exciting other than the laser electron microscopy and EUS? Anything else on the horizon which you want to share with the audience before we close the
So
show?
there's another thing that it's called spyglass procedure. So basically, every few years, as the technology gets smaller and smaller, and then we get more micronized. So all of these areas that I told you that we had, the opening of the bile duct has been so tiny that it's like the opening of a ballpoint pen. Now we have scopes that we can actually go into the bile duct with a camera, with what so much to call like a daughter scope. So your endoscope that's going in the body, then through the endoscope you put another scope inside of a scope and go into the bile duct and reach into the liver. And so very early starting cancers that are originating in the bile duct called the cholangiocarcinomas, we can diagnose them, because they are also the kind where if you detect them early, you can cure them. Otherwise, it's a really, really difficult situation. And if I'm missing something, you can prompt me, sir.
No, you're doing a great job. So let's just recap on some of the great points you brought today to our audience for the health of the liver, gallbladder, and pancreas. The first thing is moderation on alcohol. I think that's very important. And all these organs sit next to each other and they talk to each other. So if you cut down alcohol, they all three will be happy. Number one. Doesn't mean you don't have fun. You can have fun, but have fun with less alcohol. Number two, no smoking. So, that impacts your higher risk of pancreatitis, higher risk of pancreatic cancer, or any a host of other cancers. So, for if you don't want
Liver.
to liver too, yes. Number three, if you have done some, parties and things in your 20s, which all of us, were young and strong at the time, but if there is a concern, get your Hep B, Hep C testing done. And the good news is the Hep B is totally curable. I'm sorry, Hep C is totally curable if you, depending on the genotype. So that will reduce your risk of cancer of the liver. Next important point Dr. Choudhry brought up is that lifestyle modification with reducing your stress, reduce and increasing your exercise, which will help you reduce stress. And that will help you with your truncal obesity and adipose tissue, as we alluded to in a lot of our previous talks, is a serious endocrine organ. It's not a just, that it makes you look bad, but the adipose tissue produce a lot of hormonal markers, and these are also atherogenic. So, we didn't talk, though it's more advanced, we didn't talk about the ischemic aspect of these organs, but any organ can become ischemic if it's the blood supply is not adequate, and that's where losing weight will be helpful as well.
Mhm.
So reduce your BMI if you're Southeast Asian like me and Dr. Chowdhury. If your BMI is 25, don't jump up and down. Look at your waist circumference. And that's a more critical marker for Southeast Asian. And BMI of, I would say, 22, 23 is a better marker for our Southeast Asian community. Um, Anything else I missed which you definitely want to highlight? And we talked about fatty liver. Fatty liver. Fatty liver is again boils down to lifestyle changes.
Now I
Yes.
think this is adequate hydration is something that gets ignored, especially these days we're all wearing masks. We really need to make sure that you have adequate hydration. That might, concentration, so the function of the kidney, unsupervised, we really need to. You're not sleeping well, then you go get a big cup of coffee because you need to stay awake. Coffee makes you go have more, urination, and next thing you know, you're really inside is dehydrated. So your bile is more concentrated, your urine is more concentrated. You're forming stones there. You're forming stones in the bile ducts, and hydration of the liver is not there. And so hydration really needs to, and your colon doesn't want to function because you don't have as much water in your intestine, and then you get constipated, especially if you're also on a water pill. So judicious intake. And I tell people, God made lots of springs, but there were no soda springs. I don't want to bring out a company's name, but there weren't, there are no carbonated drink springs. So there's a lot of water springs. So drink water, water, and water. And in the elderly population and after adulthood, I really don't want anybody to have, packaged juices. If you're going to want to have an urge to have juices, eat the fruits. So you get the pulp, you get the flavor, and you get some of the juice, but none of the additives. So you're not putting yourself at risk for diabetes either, and hence fatty liver.
Great points. And juices is for Tropicana,
Babies.
and not for people. um,
Juices for babies.
yes. Even then, you should be careful. Um, and one other point we mentioned and we want to highlight again is less is good with medications. All those medications, supplements, over the counter, nothing is safe as far as your liver as it get older. And try to go once a year and talk to your primary care and get them reduced to as few as you can. So be proactive about that.
Right.
With that,
You bring up
Umesh,
You
Go
bring up
ahead.
a very good point. You bring up a very good point. People say, well, I'm taking these 22 supplements, they're all natural. And I point out to them with respect that even cocaine is very natural. It came from so please do not get sucked into this thing about natural. Almost everything we have that's now synthetic started out as natural. So 20 or two or three more natural additives, and you could actually have substantial damage to the liver.
And not only that, the interactions, there is so much interaction between anything supplement, prescription medication versus supplement, prescription medication versus prescription medication. So less is critical in terms of reducing the drug to drug interaction. And poor liver, it has to deal with so much
Yes.
onslaught, and it does a beautiful job, but there is a limit it can handle. So with
You
that,
cannot live without the liver.
yes. So with that, we come to end of our show, and if you can, I want you to stay. We're going to do Ujjayi breath or victory breath today. It's one of my
Please.
favorite, and it will help people with one of the tools I try to give end of the shows to help with the stress reduction. And I think breathing exercises or pranayam is a wonderful tool for our audience, and they enjoy it. And I hope they are practicing it. Now we are not doing every week, so they should be doing on their own. We got them a lot of different breathing over last 1 year and a half, so they should have enough in their toolkit. So for the folks who join us late, let me reintroduce our guest today. We had a wonderful talk with Dr. Uh, Umesh Choudhry. He is a chief of GI for Morton Plant. He has a private practice right here in Clearwater, and he has cutting edge tools at his disposal. And he does endoscopic ultrasound, and now he added laser electron microscopy to his toolkit, which is going to be a fantastic tool. In addition to EUS, he bringing to Pinellas County, and he was a pioneer in Pinellas County when he started out with EUS. So anyone with gallbladder, pancreatic pathologies, and regular GI too, he does a great job with endoscopies in general. So thank you, Umesh, for joining our webcast.
Thank you so much.
All
Great
right,
pleasure.
let's
Let's
do
do
the
some
breathing.
breathing.
Yes, sir. So
Thank you.
in breathing, the first thing you need to do is posture. You got to have a straight spine. I like to do the Ujjayi breath sitting up. So if you are reclining, make sure your spine is straight. And a lot of people don't pay attention to their spine throughout the day. And olden days, I was reading an article. Only the kings and the royal family had the chairs with the backs, and they died young. If you can have a chair without a back, just think about it. It helps your core, it helps your spine to work while you're sitting. Now, if you have a back, we have as a human has a tendency to slouch, and that's not good for anything. That's not good for your lungs, because now your spine is in a compromised shape. So think about it. If a lot of folks are working from home with COVID era, so it's good to get a working stool instead of a chair if you can. With having said that, so keep the spine straight and relax. You don't need to put too much effort in making straight. I don't want that. And then in victory breath, it's like a Darth Vader breathing. So in other words, if you try to get a mirror, remember your childhood days, and you try to uh, breathe out. So breathe out thinking you have a mirror. So breathe in through your nose, and then breathe out through your mouth. Create a hissing sound. So do it again with me. So breathe in through your nose, and then fog the mirror with a Darth Vader hissing sound. So now do it without the mirror in front, but we're going to still use the mouth. And so that's for beginners, but we'll come to the actual victory breath or Ujjayi breath after we practice this one more time. So breathe in through your nose. So some people call it a sound of a ocean. So the Ujjayi breath or victory breath has a component of a sound to help you focus in addition to the component of breathing in and out. So the sound helps you calm down when you close your eyes. You're focusing on that sound. So that helps you get into deeper meditation if you use breathing before you meditate. Or you can use breathing without meditation too. So make sure the spine is straight. Now this time, when you're breathing out, I want you to close your lips. I don't want you to leave your lips open, and focus on your this part of your throat. And I want you to tighten it up a little bit as you're getting the breath up. So that should create the sound. The sound should not come from your mouth or tightening up your nose. So it's going to be like this. You breathe in. It's good to close your eyes so that way your focus is on your breathing. So breathe in. One more time. So what I'm doing is I'm not using opening my mouth and fogging the mirror, but the concept is same. You're letting the air this time get out through your nose, and that will get you the maximum benefit. If you can't do it, you can do it through the mouth too. But the proper technique is tightening up the throat here and then breathing out through your nose. So we'll do 5 of those and then we'll call it a day. This is called victory breath. A lot of benefit. And if you have an important meeting, important presentation, do it for 5 minutes. Close your office, close wherever cubicle you have. Do it for 5 minutes. You will see that you will have such a calming effect, and you will be unperturbed, and you will perform to your maximum potential. A lot of the military uses these techniques, the breathing techniques, before they go on a certain assignment. So these are very helpful in focus for students, for people in stressful job like ours, nurses, anyone with stressful job. You can just take 5 minutes twice a day, and that will help you get focused. So let's do it. Close your eyes, keep your spine straight, put a smile on your face, and we're going to breathe in. Breathe in one more time. Two more time, breathe in. And last time. Open your eyes slowly and see how relaxed your brain is. And it just keeps you so calm. I love this, the sound aspect of this victory breath. If you can practice it on, 5 minutes, 10 minutes, whatever your schedule allows, it'll help get you a little bit more calmer, and you'll deal with the world a little bit better with this COVID anxiety we still have. And all of us should vaccinate. Just a quick reminder to all of us that vaccination is important toolkit we have now, and the supply is improving now with the vulnerable population mostly getting covered. And so there's no reason not to take the vaccine unless you have contraindications, allergies. So vaccination is going to help all of us. I took my vaccine, and Umesh just said he took his vaccine, and we're doing it for each other. We're doing it for ourselves and for the fellow human beings. So in a pandemic, we need to think about each other. And if Umesh thinks about me and I thinks about Umesh well-being, we'll be all right. So Johnson and Johnson, people talk to me, hey, it's 65% efficacious, 70% efficacious. I say, but what you're looking at is any symptom. We're not worried about any symptom. We're worried about you ending up in the hospital, on the vent, and dying. That Johnson & Johnson vaccine is close to 100% as the Pfizer, as the Moderna. So any of those threes are great. In fact, I like Johnson Johnson personally. The reason being, it hits both your cellular immunity, the T cell immunity, and your regular antibody IgG, IgM, both, like the Moderna and the Pfizer. The biggest advantage with J&J is the logistics. One shot, like Umesh pointed out, and you don't have to worry about second shots. And that, some people have a little bit more side effects with second shots because now the body is in hyper, intense state, and you get more reaction. So, and the logistically also, there's no need for special refrigerators and all that. So I think having Johnson Johnson in the mix will improve the delivery to rural areas, far-flung areas, bring it to the physician clinics, which I think is one of the areas the last mile of the vaccine has been missing. And Johnson Johnson will vaccine will add to that. So uh, please, vaccines don't cause any uh, damage. Yes, some people it does, but so does Tylenol too. So the risk benefit for the vaccine to reduce the COVID-19 pandemic is huge. And some people say to me, hey, these are based on the original genome, how it's going to be effective against strains. And I tell them a simple thing. You think about a fertile ground. If you don't give a fertile ground to even the strains, they won't have places left. And just a recent study came out on Pfizer vaccine, and I'm pretty sure it's going to come out true with other two, that it's pretty effective against some of the strains, not all of them, but some of them. So, and like with flu vaccine, which is again similar respiratory virus, we see that over the years, if you keep taking flu vaccine and the different flu strains keep mutating, there is less mortality. And talking about flu, just by wearing mask, we don't see flu.
Right, right. Yeah.
So, key is whatever vaccine is available, you don't need to be picky. Just go for it. With that, we come to the end of the show. I appreciate Umesh you hanging out and doing the victory breath with us. You had
Thank you.
something else to add?
I would be remiss if I did not pitch for my charity. I support a charity called ACAL, EKAL.org. ACAL provides one concept schooling for $1 a day for 20 to 30 children. If you are, and this is primarily based in India, but the fundraising is done all over the world. We have about over 2.7 million children now enrolled, almost 50% or more female children, girl children. And so any amount of donation in that is welcome. There is, of course, if you are of, that part of the world, then it's a great service, but world is a very small place. Now you saw in this pandemic that things can happen across the globe, so we never should think about, this is how does it bother me? I live in West Virginia. Well, you just saw how things a million miles away can affect us. So world is flat, world is very close, and education is my passion. And you can go on the site and donate. There is this weekend, of course, there is on 13th March at 8:30 p.m. There's the fundraiser Indian music function right at on YouTube, and on your computer you can see it, and on Facebook you can there is a link. You can donate right there if you'd like, and appreciate for those people that do donate. Enjoy, and education is a part of where health promotion begins. Thank you.
Great cause. I know you're very passionate about that. Thank you for
And
bringing
you've been a great
that,
supporter,
guys.
and we thank you.
Yes, we thank you for coming to the show. We come to the end of the show, and be nice to yourself, your fellow human beings. This is Dr. Mahajan signing off. We'll see you on the second Wednesday of next month with another exciting episode of from Mahajan Medical Center studio here in Largo. Ciao. Namaste.